Kia ora, Nisambula Vinaka, Assalamu alaikum and Namaste. My name's Jalal Mohammed and I'll be presenting on Reforming Primary Healthcare, Lessons from the Fijian Experience. Fiji's healthcare system guarantees health for all. The Ministry of Health is the primary provider of healthcare in Fiji, and key considerations of the system are equity and access. Healthcare is provided by the Ministry of Health through 4 divisional structures, namely the Northern, Western, Central and Eastern divisions, and these divisions are administered through a central office. Healthcare is delivered through a hierarchy of health facilities within each of these divisions. At the lowest level, healthcare is provided through nursing stations staffed by nurses who offer basic level of care. At one level above this are healthcare centres staffed by doctors, nurses, ancillary health staff who provide primary health care. There are 3 levels of healthcare centres, A, B and C, and these are based on population size served. The levels determine the quota of supplies, consumables and medicines. Generally, healthcare centres are open from 8 a.m. to 4:30 p.m. Monday to Friday, and larger ones may be open from 8 a.m. to 12 p.m. on Saturdays as well. At the next level are subdivisional hospitals that provide secondary level of care. There are 2 levels of subdivisional hospitals, 1 and 2, again based on population size served. Subdivisional hospitals are generally open 24 hours. Each administrative division also has a divisional hospital to provide tertiary level care. Now, in order to reform its healthcare system and improve quality, access, equity, efficiency, and effectiveness, Fiji attempted 2 decentralization efforts. In 1999, the first initiative attempted to devolve the Fijian healthcare system by strengthening healthcare delivery at divisional levels. Political instability, coupled with a lack of support from the Ministry of Health staff, hindered the establishment of a devolved system. Only limited delegation of delivery and organization of services had been achieved. Subsequently, in 2008, the government rolled back the decentralization initiative. So essentially what that means is they re-centralized. And then again in 2009, a small-scale decentralization was initiated in 1 division with the aim of improving users' access to healthcare. And this was the Central Division, and within the Central Division, it was primarily targeted at the Suva subdivision. This involved a deconcentration of health services from the divisional hospital to the peripheral health centers. So what that means is there was just a transfer of workload. In this case, a transfer of GOPD or general outpatient services from the divisional hospital to the peripheral health centers, which meant that users could not self-refer to the divisional hospital for the outpatient services. And this involved the strengthening of the 6 peripheral health centers, including the extension of operating hours from 8 a.m. to 4:30 p.m. Monday to Friday to 6:30 a.m. to 10 p.m. and also opening the health centers in the weekends from 8 a.m. to 4 p.m. Now this presentation is from a larger study looking at access following the second decentralization initiative. A qualitative study employing a case study methodology was employed, and there were multiple sources of data collected to allow for triangulation. 81 semi-structured interviews were conducted over 7 sites and involved 3 groups of participants, administrators, providers and patients, and this was complemented with participant observation and analysis of documents. So what did this mean in terms of findings? So what did we find? Some of the key findings were that all groups agreed that decentralization was a positive change, that implementation was rushed, and that as a result patient experience was affected. So as I said, all groups, administrators, providers, and patients agreed that decentralization was a positive change. They always started the sentence that decentralization is good, and then they said but, and then they went into the reasons as to why they felt that decentralization, or how they felt decentralization could be improved. So decentralization was rushed. And what this meant was that planning for decentralization and the implementation of the initiative were rushed, and this limited the administrators' ability to learn from early experiences. So the implications that this had was that there was a shortage in the number and mix of human resources, which affected the provision of medical consultations available for the entire duration of the opening hours for these decentralized health centers. Though there was an increase in the quota of medicines and consumables, this did not match the increased demand. As this was controlled centrally, there wasn't a decision space being transferred to the peripheral health centers, and as a result, patient access was affected. So when I say decision space, what I mean was the ability to make decisions at the decentralized health centers was limited, so they couldn't respond to the local needs in a way that met those local needs. Now, the diagnostic service provision was also affected. A full range of diagnostic and pharmaceutical services were not offered during the extended hours. This meant that while patients could be seen in the extended hours of operations, they had to come back the next day to collect medications or undergo diagnostic examinations. Now, this affected the patient experience. One of the ways that it affected patient experience was that higher utilization resulted in increased waiting time. And these decentralized health centers reported an up to 300% increase in utilization. For example, one health center, and this was a large level A health center, saw an average of 52 patients per day prior to decentralization. This jumped to 299 patients per day following decentralization. So as a result, there was a controlled distribution of waiting numbers or numbers to be seen to manage the increased volume of users. And what this meant was this impeded access to primary healthcare services and increased waiting time. So while services were extended, there were also additional disruptions to services because there was such a shortage of human resources. The health centers had to close during lunch and dinner time because there were no additional cover. So this meant that patient waiting time increased. There was also an impact on consultations. To manage increased utilization, administrators brought about a guide that consultations should be limited to 3 to 5 minutes per patient. As a result, the providers placed controls over the distribution of waiting numbers per shift to manage the increased utilization. And what patients said, when they went into consultations, because it was so rushed, they said the doctor didn't even touch me during the consultation. And this affected the interaction that patients had with healthcare professionals. So administrators noted that human resources were at a bare minimum, which affected the delivery of extended services. And providers noted that shortages in human resources hindered day-to-day delivery of decentralized health services. As a result, the decentralized health center was a tense environment. And this resulted in patients encountering poor attitudes from healthcare professionals. There were also implications on equipment. So a higher utilization meant that equipments were also needed to be upgraded. Whilst administrators noted that there were some upgrades to equipment, providers noted that these upgrades were minimal and shortages impeded the delivery of health services. And there were issues with equipment breakdowns and poor maintenance and repair of equipment. So patients felt that decentralized health centers, and what they described was that they felt it was a house with no furniture. There were also impacts on supplies, consumables, and medications. Administrators noted that the quotas were upgraded and medications in particular were replenished more frequently. However, they noted that there were several issues affecting the shortage of medication, supplies, and consumables, and they attributed this largely to a large floater user population. So floater users are those users that live in the population catchment of another health center but visit a different health center because of a wide variety of reasons, such as doctor preference or perceived better service, etc. And administrators also noted that there was an ineptness of staff to monitor and effect quota increases, which could address some of the shortages. Providers, on the other hand, noted that increases did not match the increased utilization, and decentralized health centers had chronic shortages of supplies, consumables, and medicines. They found themselves constantly noting, what are we short of this month? Patients noted that shortages were chronic and persistent, and as a result, they had to run around between health facilities to get medications or supplies and consumables needed as part of receiving health care. Now, what came about from this patient experience was that some patients engaged in practices that resulted in benefits for their access. So some of these patients, because they visited the health center a number of times, knew when were the busy periods and when were the quiet periods. So they would pick the best time to come to the health center. And some of them noted that this was very early in the morning at 6:30 a.m. when the health center opened, or early in the afternoon around 2 p.m. or in the evening after the dinner break. So in doing so, patients were making trade-offs between waiting time and the range of services they could access. So for example, they could come in the evening and wait less, but they would have to return the next day to undergo any diagnostic tests or collect medications. There was also a chronic supply shortage of medications. So where medications were not available at public health facilities, patients actively worked the system. So those that could not afford to buy medications came up with strategies. They would buy a partial course of the medicine and then buy the remaining course when they could afford to do so. So what were the implications and lessons learned from this, from the Fijian experience? So there were a number of implications on primary healthcare. Fiji's experience with decentralization revealed a context-specific incremental approach had a positive impact on primary healthcare, increasing the uptake and utilization of primary healthcare at decentralized health centers. And unlike the first decentralization initiative, it had better engagement of health professionals at lower levels. But implementation was rushed. So another understanding that arises from the Fijian experience is to stagger the implementation. Roll out the decentralization initiative to subsequent subdivisions and divisions, and allow time in between the pilot and full implementation for lessons to be learned and incorporated. There also needs to be a transfer of decision space to accompany the transfer of workload to enable health centers and staff to be more responsive to the patients and local communities in their catchment. In the case of Fiji, expansion of decision space in the service organization function would enable healthcare centers to be more responsive to the local communities. And another understanding that comes from the study is to evaluate. Evaluation offers a tool to learn from early experiences of decentralization and apply to strengthen decentralized health centers and future decentralization initiatives. And finally, there should be active participation encouraged within the health system. What the study found was that users were actively making trade-offs between the access that they had and the quality and the waiting time that they encountered. So increasing the scope for active participation of administrators, health professionals, and patients in all stages of implementation and ongoing policy and strategy development would improve patient experience and access. Implementation of decentralization in the Suva subdivision reflected a top-down approach, and opportunities for those directly involved in and affected by decentralization to influence the process were lost. So involving them in the process would improve the implementation of decentralization and ultimately improve access. Thank you for listening to my presentation. Vinaka.